I think in areas of focus are obviously anything that we're using AI that's going to have direct patient, that's going to be given to patients or going to have like a patient actionable sort of thing needs to be a priority. I think it needs to be vetted by multiple steps because having unsupervised results or in this case, like even our notes, right? Patients look and refer to them as what, oh, the doctor told me a lot of things. What do I need to look at or know about there too? And if there's a summary that's wrong or an AI generated thing is incorrect, that can cause a lot of confusion. And, they talk about patient literacy. Patient literacy is like significantly less, like, almost at a third to fifth grade level in the United States versus sometimes our notes and stuff too. So they're going to go with the survey more than that. And our study kind of shows they prefer it because it's easier. That was even providers there too. But the initial one running with patients is also showing that, you know, the patients also like, clearer language. So I think that's what I would prioritize there too. Um, yeah. I think it can be applied to any basically subspecialty field, particularly for like like for in this case was interdisciplinary communication there too. Like I don't pretend to know anything about cardiothoracic surgery, or there's like very niche like parts of medicine where I mean you only get so much exposure during medical school, and then if you do, in my case ophthalmology, I had like 1 year as like internal medicine resident. After that, it's like very niche knowledge that as the further I get away from it, the more just the terms I kind of remember and stuff too. But I don't know specific management guidelines or patterns and say like per this, these new protocols and stuff too. So I think it could be applied to any niche field, especially subspecialty medicine there too. And this was kind of reiterated in the provider comments of our study where they said, particularly in the retina clinics or the glaucoma clinics or like the cornea subspecialty clinics is you're diving not into just ophthalmology, you're diving into niche field. The primary care providers at least thought that there was the biggest benefit. So I think it could be applied to anything in that too, because it's pretty agnostic. The biggest roadblock is obviously showing safety. I mean, even in this study, right, showing that there's a 25% error rate and then there's a 50% error rate on top of that too, right? If you're going to take the time to want to deploy something and it did add some time, right? Even though most of it took less than a minute, if you're going to need to add any additional time and it's not going to be perfect there too, it's going to be hard for physicians who are, in a busy fast-paced clinic flow there too, to do that. The other thing is obviously institutional adoption, especially with these like tools. And I mean, requires specialized hardware, equipment, and stuff too. That is most clinics don't have and would need to buy. Either, you'd go through like a cloud-based provider, and then, you're talking about getting your institution or your clinic to be okay with going to that and paying this whole new stream. Because it costs, every query costs money in like that sense. In our case, we did it all locally, but still that's an upfront cost of capital cost to buy a computer that could run that too. I think those are two of the biggest hurdles in widespread adoption. I think it's going to take time, but as these models, the model we used, right, was over a year ago was like top performing open source model, but now it's like nowhere near the top of the leaderboard. The models have gotten so much better, and like the progress has been so great that these newer models, even when I try it on these summaries there too, are so much better. It's like night and day differences there too. That's a positive that as these models get better, then some of these or less. The cost one probably will still stay because I mean you're dynamically running very computationally expensive tasks, so that I don't think that one's going to go away. Yeah, I think obviously the team-based approach in healthcare is the most important thing about taking care of patients, especially as they get more complex and just in general. I mean, there's been many studies that have shown, the interdisciplinary teams, care rounds, and everything to really help patient outcomes and care. I think AI is just a supplement. They're a tool. It can be something that can just help, if we can help communicate better in different ways so everyone's on the same page, then we can better take care of our patients there too. Um, in next steps, I think using something like that for the outpatient setting is very helpful. I know for the inpatient setting too, as a resident, I would get called all the time to be like, we don't understand what's going on. Like, what is the IA team's assessment of what's going on here too? Because they didn't understand what our note was because it was like, had too many acronyms and jargon that was there too. And I mean, I read the other notes and I'm like, what is this team saying or that? So I think the next steps are trying to really take stuff that have been shown in, retrospective trials and stuff too, and really put it in controlled experiments to say, yeah, like actually we're going to get some value and we can really change patient-centered outcomes on this too. And I think that's like one of the biggest limitations of our study is we assessed, the other providers in a surveys fashion, but ideally we could show patients benefited, that's even better, right? Like if the physicians who are reading these and they're like, wow, I can change. I understand what the eye health is better, and then overall their overall eye outcomes or their overall systemic outcomes are doing better, then that's a huge win in my mind. And that's what I think we should all work towards, or that would be like the ultimate endpoint.